This video introduces you to the embryology of the pharyngeal apparatus. The pharyngeal apparatus consists of a series of pharyngeal arches, grooves, pouches, and membranes that play an important role in the formation of face and neck structures. This is a list of the learning objectives that should guide your study and understanding of the topics discussed in this video. Before embarking on this topic, you should be aware that the neck is a common site for masses of one kind or another, identified in these images by asterisks. As future clinicians, you will evaluate the neck by palpation or imaging for pathology or congenital abnormalities. Some congenital anomalies, as you will learn, do not manifest themselves at birth, but rather appear during childhood or early adolescence. As you perform your dissections of the neck, become very familiar with the location and surface projections of important bony, cartilaginous, and soft tissue structures in the neck, as these will serve as helpful landmarks in your evaluations. A sound understanding of the embryologic development of the pharyngeal apparatus and its derivatives helps in the understanding of the normal adult structures of the face and neck and in explaining congenital abnormalities when development is disrupted. Much of the face and neck are derived from the pharyngeal apparatus, which on the previous slide we said consisted of a series of pharyngeal or branchial arches, grooves, membranes, and pouches. The key word in anatomic area here is pharynx, or the throat. The embryonic pharynx is the cranial-most portion of the foregut. It is the scaffolding around which the face, palate, and structures of the anterior neck are built. This development is a dynamic process that involves movement and migration of cells and tissues. I've included a URL on this slide at its bottom to a short YouTube animation of the development of the pharyngeal apparatus that I think nicely summarizes this process. While busy, this slide nicely summarizes the key elements we will be discussing in the next several slides. It may be best to return to this slide as a quick review once each component has been described, or you may wish to create your own table listing these components. We begin with the discussion of the pharyngeal arches. The pharyngeal arches appear in the 4th and 5th weeks of development as ridges on each side of the future head and neck regions, as neural crest cells from the developing nervous system in the cranial region migrate into them. This gives the external surface of the embryo a characteristic but temporary gill-like appearance. These arches develop lateral to and support the lateral walls of the primitive pharynx. Components of these arches contribute extensively to the formation of the face, nasal cavities, mouth, larynx, and neck. 4 pairs of arches are visible externally. The 5th arch is rudimentary and never fully develops. The 6th arch is not visible on the surface of the embryo. The arches are separated externally by grooves or clefts called pharyngeal grooves or pharyngeal clefts. Opposite these grooves internally are the pharyngeal pouches of the lateral pharyngeal wall. The next slide is a horizontal section through the embryo along the red hashed line. This slide illustrates the cut view along the hashed line. Each pharyngeal arch is covered externally by ectoderm and lined internally by endoderm. Each arch contains a core of mesenchyme or embryonic connective tissue consisting of paraxial mesoderm that is augmented by cranial neural crest cells. Each arch contains an artery that arises from the truncus arteriosus of the early heart and connects to the dorsal aorta. Cartilage that forms the skeleton of that arch. Mesoderm that differentiates into skeletal voluntary muscle of the head and neck, and a cranial nerve that supplies sensory and motor innervation to the mucosa and muscles derived from an arch. This slide depicts the pharyngeal grooves or clefts as invaginations between the arches and their fates. 4 grooves develop bilaterally during the 5th week of development, but only the first groove persists postnatally as the external auditory meatus or ear canal. Pharyngeal membranes form at near points of contact between a groove and a pharyngeal pouch, with a small amount of mesenchyme intervening between the linings. The circles that I'm drawing on both of these illustrations depict the location of our first pharyngeal membrane, which will persist as a tympanic membrane or eardrum. The other pharyngeal membranes disappear. Well, what happens to the other three pharyngeal clefts? After proliferation of mesodermal tissue in the second arch causes it to grow and overlap the third and fourth arches until it fuses with the epicardial ridge in the lower part of the neck to give the neck a smooth external contour. The second, third, and fourth grooves subsequently lose contact with the outside and temporarily form a cavity lined by ectoderm called the cervical sinus. These cervical sinuses normally become obliterated and disappear. What happens should a cervical sinus fail to regress and disappear? This may lead to formation of lateral cervical cysts indicated by the swellings in the photos on the right, or cervical sinuses or cervical fistulae that appear along the anterior border of the sternocleidomastoid muscle. Cervical cysts typically don't appear until late childhood or early adulthood, when they appear as slowly progressing, soft, painless neck masses anterior to the sternocleidomastoid, oftentimes just below the angle of the mandible. The persistent epithelial lining of the cervical sinus may produce fluid over time, and cell debris accumulates from cells that are shed from the epithelial lining. Should there be failure of the second pharyngeal groove and cervical sinus to obliterate, a channel may develop from the cervical sinus to the skin of the neck called an external cervical or branchial sinus, as indicated in illustration D. A sinus is simply a channel or hollow space. Conversely, internal branchial or cervical sinuses may develop between the cervical sinus and the lining of the second pharyngeal pouch in the neighborhood of the palatine tonsil, as indicated in illustration D. Cervical fistulae may form as a channel or tract opened internally at the site of the palatine tonsil and externally in the side of the neck, as indicated in illustration E, due to persistence of the second pharyngeal groove and second pharyngeal pouch. A fistula is an abnormal passage from one epithelial surface to another epithelial surface. Here, mucus secretions may be discharged onto the skin surface. Let us now turn our attention to the pharyngeal pouches and structures derived from them. These are listed in the lower left-hand portion of this slide. There are four pairs of pharyngeal pouches. These are endodermally lined outpouchings of the lateral walls of the primitive pharynx. The first pharyngeal pouch elongates and its distal end enlarges to form the primitive tympanic cavity or middle ear cavity. Its proximal part connects the middle ear cavity to what will be the future nasopharynx and becomes our auditory tube, also known as the eustachian tube or the pharyngotympanic tube. The second pharyngeal pouch is involved in the formation of the palatine tonsils and forms the surface epithelium overlying them. The third pharyngeal pouch expands into adjacent mesenchyme and develops so-called dorsal and ventral wings. The epithelium of the dorsal wing develops and becomes the inferior parathyroid gland. The epithelium of the ventral wing develops into one of the lobes of the thymus gland. Eventually, both primordia lose their connection with the pharyngeal wall, and the thymus then migrates towards the superior mediastinum in a caudal and medial direction, pulling the inferior parathyroid tissue with it. The parathyroid tissue finally comes to rest normally on the posterior surface of the thyroid gland and form the inferior parathyroid glands. The epithelium of the fourth pharyngeal pouch also expands into adjacent mesenchyme and develops dorsal and ventral wings. The epithelium of the dorsal wing develops into the superior parathyroid gland. When the parathyroid tissue loses its contact with the wall of the pharynx, it attaches itself to the caudally migrating thyroid gland and takes its final position on the posterior surface of the upper lobes and becomes the superior parathyroid glands. Note their switch in position as they migrate. The parathyroid glands produce parathyroid hormone, an important hormone that acts on osteoclasts to increase resorption of bone and hence increases serum calcium levels. The ventral part of the fourth pharyngeal pouch develops into the ultimobranchial or ultimopharyngeal body. This also fuses with the migrating thyroid gland. Its cells become disseminated within the thyroid gland and give rise to the parafollicular cells of this gland. These cells produce calcitonin, a calcium-regulating hormone that decreases blood calcium levels. For this reason, they are also known as the C cells of the thyroid. We now move on to describe the hard tissue elements within each arch and their derivatives. These are indicated by different colors as shown in the illustration below. Skeletal structures arise from neural crest cells. The first pharyngeal arch is often referred to as the mandibular arch and is involved in the formation of the upper and lower jaws. It consists of two paired processes or prominences called the maxillary and mandibular processes. These border on the primitive mouth, also known as the stomodeum. The maxillary processes give rise to the maxilla, the zygomatic bone, and the squamous part of the temporal bone. The mandibular processes contain a bar of cartilage known as Meckel's cartilage that is closely related to the developing ear. The dorsal part of this cartilage will develop into two of the three middle ear ossicles, namely the malleus and the incus. The middle part of this cartilage regresses and its perichondrium persists as the anterior ligament of the malleus and the sphenomandibular ligament. The ventral part of this cartilage forms the primordium of the mandible, around which the bone of the mandible grows via intramembranous ossification. We will return to the mandibular arch at a later point when we discuss the development of the face. The second pharyngeal arch is also named and is called the hyoid arch. It contains a bar of cartilage as well, known as Reichert's cartilage, that is closely related to the developing ear. The dorsal part of this cartilage ossifies to form the third ossicle, the stapes, and the styloid process of the temporal bone. The ventral part of the cartilage ossifies to form the lesser horn and the superior half of the body of the hyoid bone. The intervening segment of cartilage regresses, and its perichondrium persists as the stylohyoid ligament. The cartilage of the third and fourth arches are unnamed. The cartilage of the third pharyngeal arch is located on the ventral part of the arch and ossifies to form the greater horn and lower half of the body of the hyoid. The cartilages of the fourth and sixth arches fuse to form the cartilages of the larynx except for the epiglottis. The epiglottis, as we will see shortly, arises from the mesenchyme in the hypopharyngeal eminence, a swelling on the ventral surface of the pharynx that is derived from the third and fourth arches. We wrap up our discussion of the derivatives of the pharyngeal arches by listing the skeletal muscles that arise from the paraxiomesoderm within these arches and the cranial nerve that provides motor innervation to them. Because of the unique origin of these muscles, you may hear or see reference to a special kind of functional fiber type within these cranial nerves known as SVE or special visceral efferent fibers. Beginning with pharyngeal arch 1, the mesoderm of this arch forms the muscles of mastication, of which there are four pairs: masseter, temporalis, medial pterygoid, and lateral pterygoid. In addition, the mesoderm of this arch gives rise to the mylohyoid, anterior belly of digastric, and the two tensor muscles, tensor veli palatini and tensor tympani. The cranial nerve of this arch is the mandibular division of the trigeminal nerve, or the third division of the trigeminal nerve, often referred to as V3, and it is this division only that contains motor fibers. The first and second divisions of the trigeminal nerve are sensory only. The mesoderm of arch 2 gives rise to the muscles of facial expression, of which there are many. They are not listed, however, on this slide. You'll learn those in lecture and in your dissections. The mesoderm of this arch gives rise also to the stylohyoid, posterior biliary digastric, and the stapedius muscles. The cranial nerve of this arch is the facial nerve, or cranial nerve 7. Arch 3 mesoderm gives rise to only one muscle, the stylopharyngeus muscle, which is a muscle of the pharyngeal wall. It is innervated by the cranial nerve of this arch, the glossopharyngeal nerve, or cranial nerve 9. Arch 4. The mesoderm of this arch gives rise to the cricothyroid muscle, one of the intrinsic muscles of the larynx, the levator veli palatini, a muscle of the soft palate, and the pharyngoconstrictor muscles. These muscles are innervated by the vagus nerve. However, specifically the superior laryngeal nerve is the motor supply to the cricothyroid muscle, whereas pharyngeal branches of vagus provide motor innervation to the levator veli palatini and the pharyngoconstrictor muscles. The mesoderm of the 6th arch provides the remaining intrinsic muscles of the larynx, and these muscles are innervated by the recurrent laryngeal nerve. Simultaneous to the developing structures we just outlined is the development of the thyroid gland and tongue, which will be discussed next. The thyroid gland is the first endocrine gland to develop. Its development is marked by an evagination or outgrowth of epithelium in the floor of the primitive pharynx during the 4th week of gestation, coincident with the development of the tongue. This occurs at the future site of the foramen cecum of the tongue. The thyroid gland then descends in the neck anterior to the developing hyoid bone and laryngeal cartilages as indicated in figures C and D. During its migration, it maintains connection with the tongue by a narrow epithelial channel called the thyroglossal duct. The gland assumes its final position in the neck by the 7th week, and then the thyroglossal duct normally degenerates. The gland begins to function in the 3rd month of gestation. A pyramidal lobe occurs in a significant portion of the population and represents an upward projection of glandular tissue from the isthmus. The pyramidal lobe represents a persistent lower portion of the thyroglossal duct. Look for the presence of a pyramidal lobe in your dissection of the thyroid in the lab. Because of the dynamic elements of its development, thyroid malformations may occur and present as masses in the oral cavity or swellings in the midline of the neck. This is important diagnostically. Recall that cervical cysts and sinuses present in the neck laterally in relationship to the sternocleidomastoid muscle. Thyroglossal duct cysts may develop from remnants of the duct anywhere along the course taken during embryonic descent of the gland. They usually lie just inferior to the hyoid bone. These cysts are generally painless and asymptomatic unless infected. They progressively enlarge during childhood or early adolescence and are mobile. They will elevate in the midline when the patient is asked to protrude their tongue. The cysts are lined by epithelium remnants of the duct and consist of fluid and desquamated cells. Thyroglossal duct sinuses, as indicated by the magenta arrow in the lower photo, may open in the midline of the neck anterior to the thyroid cartilage as a consequence of perforation of the skin following an infection of a cyst, in which case mucous fluid is expressed onto the skin surface. Thyroid tissue that fails to migrate into the neck may appear in the tongue as ectopic thyroid tissue. This is referred to as a lingothyroid. Biopsy of this mass would demonstrate normal appearing thyroid follicles as indicated in the histological slide in the upper right portion of this slide. The photos on the lower part of the slide show examples of ectopic thyroid tissue resulting from incomplete descent. A midline mass appears in a 12-year-old girl who presented with a lump high in the midline of her neck. An ultrasound showed a solid mass. When imaged by nuclear medicine as a thyroid scan, no isotope uptake was shown in the usual thyroid area, but active radionuclide uptake was indicated by the mass, indicated by the arrow. When you encounter the gross anatomic details of the tongue, you will be surprised by its apparent complexity. This is due to its rather complex embryologic development. Once you understand it, the gross anatomy makes sense. The next few slides present the essential details of this process. The tongue begins to develop during the 4th week from mesenchyme in the floor of the primitive pharynx. In the illustration, you are looking down on the floor of the pharynx. The mucosal surfaces of the tongue are derived from the 1st, 3rd, and 4th pharyngeal arches. The tongue musculature is derived from myoblasts migrating from occipital somites accompanied by the hypoglossal nerve. This nerve is the principal motor supply to the musculature of the tongue. As you will learn, the adult tongue is divided into 2 parts, an anterior 2/3 or oral part and a posterior 1/3 that is related to the oral pharynx. The next 2 slides describe the formation steps of these 2 parts. The anterior 2/3 or oral part of the tongue is derived from mesenchyme in the ventral medial parts of the first arch. These parts form 3 swellings, a median or midline lingual swelling and 2 lateral lingual swellings. Directly behind the median lingual swelling is the foramen cecum. Recall that this is the initial site of the development of the thyroid gland. Proliferation of mesenchyme within the lateral lingual swellings rapidly increases, causing these to overgrow the median swelling and fuse with one another, as indicated by the red arrows. These form the anterior 2/3 of the tongue. These swellings unite in the midline and form an internal lingual septum that is denoted by a midline groove. Formation of the posterior third of the tongue, or the pharyngeal part, is indicated by 2 midline elevations that develop caudal to the foramen cecum. The copula is formed by fusion of mesenchyme from the ventromedial parts of the 2nd arch, and the hypopharyngeal eminence arises from fusion of mesenchyme from the ventromedial parts of the 3rd and 4th arches. With further development, the copula is overgrown by the hypobranchial eminence and disappears, as indicated by the black directional arrows in the middle illustration. The posterior 1/3 of the tongue is thus formed by the cranial portion of the hypopharyngeal eminence. The caudal portion forms the root of the tongue and the epiglottis. The line of fusion between the anterior 2/3 and posterior 1/3 of the tongue is demarcated by a V-like groove called the sulcus terminalis, or terminal sulcus. At the apex of this V is the foramen cecum, which is recognized as a blind pit when probed in the lab. Because of this complex formation involving portions of several pharyngeal arches, the tongue receives innervation from multiple cranial nerves. In fact, it receives innervation from 5 different cranial nerves. The general sensory supply to the anterior 2/3 of the tongue, mediating pain, touch, temperature, and pressure, is via the lingual nerve, which is a branch of the mandibular division of the trigeminal system. The special visceral sensory supply for taste in the anterior 2/3 is mediated via the chordotympany branch of cranial nerve 7. General sensation, as well as for taste to the posterior 1/3 of the tongue, is via the glossopharyngeal nerve. This nerve also mediates the sense of taste from taste buds that reside in the circumvallate papillae, donut-appearing structures that are arranged in a single row anterior to the sulcus terminalis. A small area near where the tongue connects to the epiglottis is supplied by the vagus nerve. All the intrinsic and extrinsic muscles of the tongue are innervated by the hypoglossal nerve, except for the palatal-glossus, which is supplied by the pharyngeal branches of vagus. Some common defects of tongue development include ankyloglossia and bifid tongue. The word part ankylo refers to fixed to. Ankyloglossia, or tongue tie, is a common defect that results from a short frenulum connecting the undersurface of the tongue to the floor of the mouth. This fixes the tongue and interferes with protrusion and makes breastfeeding difficult. The frenulum, however, usually stretches with time and does not present a problem, or it can be surgically corrected. The photo on the right shows a bifid or forked tongue resulting from incomplete fusion of the lateral lingual swellings. On a lighter note, and as our last slide, you may see individuals or patients who have voluntarily had their tongues divided along the midline lingual septum in a procedure called tongue splitting. These obviously are not congenital anomalies. Make an effort to relate the adult structures you encounter in the lab with their embryologic history. You will find that both support each other as you work to assimilate this information. Good luck with your studies.